quality care, and not just more.
Hi everyone, I'm Dr. Faisel Syed.
And I'm Dr. Dan McCarter.
And you're listening to Faisel and Friends, where we believe access to primary care is a right, not a privilege.
Faisel and Friends is brought to you by Primary Care for America, a diverse collaboration of innovators leading the way towards comprehensive, continuous, and coordinated primary care.
Today, we're talking to Dr. Mark Gwynne from UNC Health Alliance about pursuing equitable access to high-quality care. Let's get started.
Hello, Dr. Dan.
How are you? I hope you've got your hatches battened down well in the storm.
We do. We're at sustained 35 mile an hour winds, and we've got 50 to 60 mile an hour gusts outside. In a couple hours, it'll be 50 miles an hour sustained and 72 mile an hour gusts. So the kids are excited. It's like camping at home, right?
Where are you calling from?
Hi there, Dr. Gwynne. It's nice to meet you. I live just north of Tampa in a small town called Odessa. And so we've got this storm outside and power outages here in the Tampa Bay area. Of course, it happened just in the last half an hour, and I was in a frantic, nervous, how are we going to record this? And Drew and Jess, as always, are so good with helping keep the show moving. And we're so excited to have you come on. A big passion of both me and Dr. Dan over the years has been the transition with providers and practices from fee-for-service to value-based care. And we're so excited about the work you've done. So I guess I'd like to start off, we usually like to start off with a question. I'd like to know what motivated you personally to help lead the transition at your system from the established, what we know, fee-for-service model we're all trained in, to the relationship-based, the value-based care model. And how has this journey shaped your view on the doctor-patient relationship?
What a great question. I love the last part of your question. How has this shaped the doctor-patient relationship? That's, the doctor-patient relationship is at the core of all of this, right? I've been asked that question a few times over the past several years. And my answer I don't know if this resonates. This is just what makes sense to me. This is how medicine should be practiced. And that's just been how I've approached this since I was a resident. I remember even as an intern looking around and saying, how can my patients who have uncontrolled diabetes don't have food? How can we focus on that? And my first clinical role after residency was in rural North Carolina, and I say that rural with a capital R. With all of the lack of resources that comes with rural healthcare. And I was taking care of our teachers and our police officers and the community. And it became really quickly apparent to me that my front desk staff, their cousin was the teacher. It was such an interconnected community that the support systems were there for some and weren't there for others. And so what I saw in my office, and then what I saw in the local emergency department, which I also helped staff, and what we saw in the local critical access hospital, we saw every gap in our system that patients fell through. And so really it became our job to fill those gaps. So early on, I called our team the spackle of healthcare. And can you do all of that within a fee-for-service framework? No. Did we keep the lights on? Yes. And we did what we needed to do to keep the lights on. But really, we tried to focus on all of these other surrounding issues that we knew our patients were challenged with and suffering from. So truthfully, as my career progressed, it became a pretty easy transition for me. One of the earlier initiatives that I really helped develop was around bringing clinical pharmacists into primary care. And to me, it was never an infringement on my autonomy as a physician. It was really just a natural extension of a care team. And I have no problem saying that our clinical pharmacists manage diabetes better than I do, and they manage hypertension better than I do. And we published on that. So the extension of the care teams, whether it's clinical pharmacists or social workers or nurse care managers or community health workers or ... whatever that is, I know that we can provide better care as a team. And that just, again, seemed like the right thing to do. And so when the opportunity presented itself within our system to help lead this effort, not just at a practice level, not just at a regional level, but at statewide health system level, I jumped at that opportunity.
Well, hearing you speak, I mean, you sound like the family doctor in all of us, right? I mean, what appealed to you was the doctor-patient relationship, and even as you were talking about what came naturally to you, you were talking about especially when you're in the rural practice, it was the relationship between your team members and the patients, the relationship between you as a physician and the team. It wasn't a big deal to add more members to the team. It's like, hey, come on,
Come
let's
on.
bring some more people to help us do this very difficult work. And I've never, ever heard any physician or any guest come on. I mean, we've had like now over 150 episodes, and nobody ever described the healthcare delivery team as the spackle that hold it all together. So, well, that's an incredible. It's incredible how you started in rural health, even staffing the emergency room. That's great. But then when you came over to UNC Health, the UNC Health Alliance, like, we have many students. Most of the people who listen to this are residents or students, people who are geeky about primary care, about a relationship-based delivery model. They love to hear the stories because we all start off somewhere. And so you started off in rural health, and now you've come over to UNC Health Alliance. Like, what was your vision for the value-based care model? Like when you first started communicating that vision to the team at UNC and like all the key stakeholders?
Yeah, it's another great question. I'll tap into one thing that you've said a couple of times as well. Something I talk to our teams about all the time is we are in the relationship business. That's what we do. Longitudinal healing relationships is what this is all about, and a focus on that, a focus on longitudinal relationships, a focus on healthy, productive relationships with patients, families, and communities. That's a theme that I really try and talk a lot about. It not only resonates, I think, with physicians and other clinicians, but it resonates with our analysts, and it resonates with folks behind the scenes around population management. So it's a theme that I really try and bring to the table as much as possible. And I tell patient stories all the time so that teams can try and connect with that, patients I've known for 20 years since residency. I think that didn't answer your question though. Your question is a really good one, in that I'm a student of quality improvement. I'm a student of organizational design, as well as a physician. So I've really, early on, we focused a lot on quality improvement. What are the principles? What are the people's processes and technology that we need, and the data systems that we need in place to make data-informed decisions and to build programs around data and actually what our populations need. The number of times I've said population health 101 is define the population and understand what they need as kind of a core driving force and kind of a core tenet of the work. That's where it started. And quality improvement, one of the core principles of quality improvement is define the problem, try a solution, figure out what works, and scale what works. And the concept of PDSA cycles is real, and we do that on a small level, and we do that at a really large level, at a system level now. So those are kind of the core building blocks. We're still rooted in the core principles of the patient-centered medical home, and then I would expand that to the 10 building blocks that Tom Bodenheimer outlined really well for us. Those are still the core building blocks in my mind of primary care, and then as an extension, population health and value-based care. And then as we built programs and initiatives around quality, that engine of quality improvement is really strong, and we can just pivot it to focus on something else, like social determinants of health screening, or like solving for transportation, lack of transportation, or solving for a health inequity. And trying to close the gap around diabetes care or hypertension care. So the core of quality improvement, I think, is really, really important, and using those principles. I could talk about a lot more, but that's kind of one of the basics.
As a physician leader, so now you're coming in, you're a physician leader, you're leading this change. I mean, there must have been, like, early on, we talk with a lot of primary care doctors, a lot of family doctors who are still mostly fee for service, and they're struggling. They're struggling with like 2-3% margins. We've had some guests talking about these very low. Some of them are doing better than that, but we're hearing a lot of these very small margins. They're just barely getting by in fee for service, and there's so much concern about like all the hurdles that you got to face with taking on more responsibility. So as a doctor leader, like what were some of the main hurdles that you had to face and overcome? And especially being a physician leader, like what were some of the strategies that you used to help the team overcome those challenges?
Yeah, I think so. A couple of principles, and then maybe a couple of practical solutions. So one of the core principles that we've also really tried to adhere to is the concept of value is really easy to sell. It's really easy to adhere to. Better quality at more affordable, accessible care. We should all agree to that. But it's how you operationalize it is really, really important. So we tried to create a network that was built on good data systems and data driven. We tried to build a network that was payer agnostic. So meaning the solutions that we're bringing to practices and the providers that you're talking about tries to bypass a physician focusing on a payer source and more focusing on the systems of care they deliver within their practice and how we can facilitate different systems of care and care design to take the complexity of payer-specific initiatives and quality measures and all of that to kind of take that out of the mix. And one of our mantras is our job is to take the chaos of value-based care and make it digestible and easy to implement at the frontline care team level. And we're well aware that many of our practices are living on that sometimes even 1% margin, let alone 2 to 3% margin. Actually, one of our challenges 2 weeks ago was figuring out how to float a line of credit to one of our practices because they were out of cash flow. They were going to really not meet payroll in 2 weeks. And they've been with us for 5 years around value. We've been able to help support their practice because they were really underwater with new value revenue, whether it was quality incentives or shared savings. And as the alternative payment model bonus, for some of your listeners, you can look that up, the AAPM bonus that CMS provides for practices to participate in advanced payment models, that's been decreasing over the past few years. And these practices became a bit reliant on value revenue to stay afloat. And so that's even a bit of a different dynamic. And this practice in particular did the right things. They converted one of their nurses into a nurse care manager. They brought in a behavioral health provider. They were doing the right things within a new care model that helped improve the outcomes of their patients and meet the local needs. And one of our jobs is to now provide a sustainable financial model, not just for the next 12 months, but for the next 5 years. So this practice and the common experience among others like them have really forced us to figure out and to change how we distribute new value revenue into the network. So there are a lot of concepts in there, a lot of core principles. The other core principle that we've tried to bring is that we're one network, and we rise together and we fall together. So there are independent practices that have solved for very local problems, and we have our employed practices where we have all of their data because we have the same EMR and we can report really high quality. So our overall network benefits from really high quality outcomes, and our employed network, which tends to be a little bit more costly than our independent network, benefits from the total cost of care improvements that our independent network can achieve at a faster pace than our large mothership.
And so with the patients, one of that I was we're looking up your bio, and I mean, this has been tremendous. I mean, I've read about large practices before, but my God, over 300,000 patients. How have you seen like this relationship-based model improve the health outcomes for your patients, but in particular, not just, the patients in your network, but in particular, those with multiple chronic conditions? When people will say, well, people who are very sick, it's difficult. People have multiple systems impacted. They're taking a lot of medicines. They're seeing a lot of specialists. Like, would love to hear about how you've seen this relationship-based model improve health outcomes, specifically those patients in your network who have multiple chronic conditions.
Yeah, that's what this is all about. It's finding those patients that are pretty complex or what we call about to be sick, and trying to prevent that transition into being sick. That's what all this work is, really working with those that are healthy to stay healthy. So, one of the other core principles of population health is risk stratify the population, segment the population, so that we can deploy resources that are common among common patients in a way that takes advantage of economies of scale. So risk stratifying super important, segmenting really super important. But I remember early on, this is the first year that we started doing this work. I was looking through some patient charts and I saw a young woman, I think she was in her 30s, maybe 35, 36 years old. And I saw that she had a couple of CAT scans in the past year because we had access to most of her data. And so I started digging a little bit more, and she had 28 CAT scans, 28 high cost imaging, including CAT scans and MRIs over a 3.5 year period. 28 different hospitals, different offices, different radiology groups, none of which were talking to each other. That was, I'll tell you, I've had a couple of kind of inflection points in this work, and that was one. I was like, wow, this is different. Finding this is patient harm, really, from an exposure, a radiation exposure standpoint. But there's not a single doctor that took care of her that knew all of that. But now I did. And so that's something we can intervene on. Another case that was another inflection point for me, we had a gentleman in one of our rural counties that was on dialysis, and he had 6 admissions to the hospital the previous year, 4 of which were to the ICU. And when we started looking at it, they were all on, he was admitted on a Sunday or Monday every time. And so, interesting, there's a pattern there. Why is there a pattern? Being a student of quality improvement, you ask your 5 whys. And so I'll ask you. So his dialysis was Tuesday, Thursday, and Saturday. And he ended up in the ER Sunday and Monday every time. Why might that be? And I ask our residents this all the time. Transportation. He had public transportation on Tuesday and Thursday to dialysis, but not on Saturday. That's a solvable problem. It's solvable. We got him transportation to dialysis, and guess how many hospitalizations and ICU stays he had the subsequent year, right? I mean, it's pretty significant, right? And I can give case after case after case of pattern recognition that, without kind of looking across a population or across a region or across a practice, it's really hard to see those signals out of the noise. But once you start looking, we find them all over the place. And then now we can really design systems of care or resources. I'll give you another rural county. We looked across our entire network across the state. And this one county had the highest ED per 1,000 utilization rate. So the number of ED visits per 1,000 patients in a region by far. And I'll give you the number. It was 1,400 ED visits per 1,000. A really well-managed population is 300 to 400. So it's really, really high. And so we dug into it, and it was really about 160 or 170 patients that were driving more than 50% of the visits. The most common diagnosis was respiratory and COPD. So we went to the region and said, primary care docs, come to the table, ER docs, hospitalists, local health department, local home health agency that provided oxygen, a community paramedic group, and the local public health department that had a tobacco cessation program that was really underutilized. So as a community, or what I call a medical ecosystem, they designed care plans for these 160, 170 patients for whatever touch point they had within that ecosystem. Everyone knew what the care plans were. And the community paramedics would visit them once a week or once every other week. That ED utilization rate dropped to 800 within about 6 to 9 months, and it stayed that way for years. So that's different. It's just a very different way of looking at care.
I mean, the other thing, Faisel and I have talked a lot about this, is getting primary care in all the wrong places. And I know the emergency room is always open, but it tends to be pretty fragmented care. It's you don't know who you're going to see. It's not scheduled. It's hard to go to an emergency room without getting a CAT scan anywhere that I've seen. And so you're getting radiated at the same time, and yet we struggle. I don't know. I mean, I know Virginia just ran the numbers, and the percent of the primary care dollar being spent, healthcare dollar being spent on primary care is about 4%. And we know that primary care is the only specialty that improves outcomes and lowers cost of care. You would think we should think of a way to invest more rather than getting people to do the right things and then change. As you talked about that practice you're helping out, and I'm glad you're able to help them out because they've done the right things. They adapted to a different model, and now somebody said, well, that's great, you did that, but now we're not going to pay you for it anymore. But it's sort of tough for somebody like that to understand, isn't it?
It is. I agree, and I think that's one of the roles of people like me and organizations like ours is to help interpret all of what CMS, what CMMI, the new models they're developing. In our case, in North Carolina, what North Carolina Medicaid is developing, and interpreting them in a way that rural practices can understand and engage with. And the optimism is that CMMI and CMS understand this with programs like Making Care Primary and some others that are really geared toward small rural practices. I have a little bit of hope that we're still working in the right direction. It's certainly more work to do, but the work hasn't stopped.
Yeah, no, and we've been fortunate enough to talk with some of the people at CMS, and they want to do the right things. I think there's a mindset that you're going to make change fast. I mean, I think we've seen that in some of the primary care, right? I mean, Walmart was going to go in and cover the earth with primary care offices, and they realized it wasn't quite as easy as they thought it was, and now they're backing out of it. And yet, again, the practice you were talking about, they had rolled up their sleeves, done the right thing, providing care in an area of need. And how we continue to support them as a society, I don't know. And I'm sure that you probably don't have the answer either, but just how do you suggest people adapt to that when they go in? If you go all in, then you can be sort of, what's the term Warren Buffett used? You find out who's swimming without their shorts when the tide goes out. So, and when you're dealing with a 2% margin, it doesn't take much of a tide going out to leave you standing there in a vulnerable position.
It is a really, really good question. I like the Walmart example you brought up, and I'm going to tie it back to relationships matter, especially in primary care, and longitudinal relationships matter. And we can dissect why Walmart Health didn't necessarily work, but fundamentally, I think that's what it's about. And Dan, you asked the big question: how do we support independent practices and smaller practices who are vital to communities and don't want to be acquired by large systems for any number of reasons? And how do we make sure that they are sustainable? It is the question for rural healthcare across the U.S. We're a rural state, so it is a question that we struggle with every day. And you're right, I don't have the magic answer. If I did, we would have solved it, 10 or 15 years ago. But what I can say is solving local problems is really, really important, whether it's behavioral health, substance use, bringing in specialty care that doesn't remotely, whether that's through virtual or other mechanisms. I think we have more tools in the toolbox now than we had perhaps even 5 years ago. I would say even perhaps before COVID. I think we understand more about what some of the drivers of poor outcomes are in our rural areas. We have decades worth of public health data that has told us over time what those issues are, but we're actually now starting to pay attention to it. And I think that's different as well. I didn't answer your question if you didn't tell.
Tis the season for not answering questions, right? During the political season.
I mean, at the core of it, we were all trained in this fee-for-service model. Most of us were trained in a hospital-based, even family medicine, residency training programs. And then, you've got physicians who are set in, okay, this is the devil I know. And now, I feel it that, we've got to move more towards a model that'll restore the doctor-patient relationship. But I think what you've been talking about, this whole time, and it seems like you've made an entire career with how to inspire doctors who may have been hesitant.
I think that's right. I've known enough primary care doctors, family doctors in particular, that got really tired of being on the treadmill. And you can only do that for so long, and then write your notes at 11 o'clock at night on the couch, the pajama time, and then also make sure that your rev cycle folks are capturing everything they can so you can keep your lights on. It's complex. And so really thinking about a different financing model and then a different care model design is, I think there's hope in that for many of the frontline doctors that I talk to. And they're also looking for partners, and that's why I feel really good about the work that we do. I think we provide some of that core infrastructure and foundation that smaller practices can plug into. And I'm grateful for other systems out there. I used to talk about Aledade as a competitor of ours. And for some of your listeners, if you don't know Aledade, again, worth looking up. I really see folks like Aledade are playing a pretty important role for some of our independent providers. I know there's an attraction also to what we're now calling corporate-backed primary care. The One Medical and City Block and others. There's an attraction to that, smaller panels, higher complexity care, and sometimes you can really provide much better care. One of my mantras and my approach now is that's really good for small populations. But I think what we're really trying to do is fundamentally change the care across the entire continuum, whether it's in a practice or an emergency department, in a hospital, in a nursing home or a post-acute facility. There are roles for all of these different types of care models within, again, what I call the broader medical ecosystem. And that's different. And I think that there's hope for our younger physicians where they can see a career path in multiple different ways, depending on what's really driving them.
I was saying, when he was talking earlier about population health and being able to stratify the population, because, as doctors, when you're working in that, gosh, like when you describe that hamster, it really is. You have 2,000, 2,500 patients, they're chasing their tails, and they want to do the best they can with, at my community health center, we weren't even at 2 visits per patient per year. And so the relationship, it was just survival, practicing, doing as much as we can in a very little bit of time and trying to do everything for everyone. And then you get into these value-based care relationships, and it's like, okay, we got to look at the whole population. We got to dissect it. Like you had in that rural community, 150 or 160 people who were going regularly for COPD or asthma exacerbations, and you were able to target them and bring everybody together, right? And create a plan so that everyone was talking the same language and the plan was being implemented. I don't think you would have been able to do that without the data. So I think that's one of the tools that we could use with providers, especially the independent ones, that, hey, it may seem terrifying because you've got a couple thousand people, but you don't have to do everything for everyone. Here's the role of this type of data, right? That can help you create a strategy to influence how you move forward in a value-based care model.
I completely agree. That's the transition from reactive care to proactive. And it's also an easy sell for some of our younger doctors that it's really important to see people that come to us. But it's equally as important, sometimes maybe even more important, to understand who's not coming to us who should be, and having systems in place to do that kind of outreach. And we've learned a lot over the years, especially through COVID, what kind of outreach works for different people. And that's been fascinating. I'll be honest with you. That's been really, really fascinating and eye-opening. And it also highlights fundamental inequities in access to care that, again, we've known have existed for a while. Now we can't really ignore it anymore. Which it really speaks to my soul as a family doctor.
You said during COVID that some of the outreach surprised you. I know a lot of large systems that were just starting to move into value-based care, when COVID happened, they said they pulled all their resources away from it and said, this is never going to work, and they backed away from it. It seems like UNC probably had a different experience with COVID. I was just wondering how it worked there.
I'll tell you, COVID was terrible. It was really on many different levels. There were a couple of silver linings for us, and this was one of them. We pivoted our entire population health infrastructure and data and analytics infrastructure to COVID and managed people at home that had tested positive through chat technology and others, with a clear escalation pathway to a nurse who then could speak to somebody if some of their answers were starting to fall into the yellow or even red zone over 24 hours, for example. We could understand testing, who was coming in for testing. We could understand vaccines, who we were administering. This is a great story. Another one of our rural counties that is 44% African American by demographics. When we first distributed vaccine to that county, the first 2 weeks, 95% of patients that were getting vaccine were white, and more than 70% of them had a home zip code outside of the county. That was access. That was everything about people knowing how to navigate the system and quickly accessing vaccine. And so through our, we saw that. So there are, very specific outreach efforts and local efforts to shift that within 2 weeks. Within 2 weeks, vaccine access mirrored the county demographics. That's using a population-based approach to access to care, and really, really interesting. So we took it as an opportunity. We used that also to kind of redesign the filters through all of our data. So today, pre-COVID, I couldn't do this. Today, even for my own patient panel, I can tell you outcomes for every patient population. Pick your metric, whether it's diabetes or prevention, utilization, cost, or almost anything else. I can tell you for my own panel the difference in diabetes outcomes for African American patients and white patients on my own panel. Every doctor in our system who's on Epic can do that. That's different.
Love it. And that's using the Epic?
It's using Epic as our main EMR. We have 45 EMRs across the network, but using Epic and then our back-end data solutions. So.
That is awesome. I love that.
It is powerful.
Let's say for the residents, I mean, first of all, thank you so much. This has been a great conversation. Dr. Dan and I spoke quickly before this when the power went out, and I was like, no, we got to figure out a way to still record this, because I love it that we've got a family doctor leading such a big movement at at an institution like where you've been at, but specifically for the students or the interns or the residents out there, like what would be the advice that you give to them about the importance now with like what the story that you mentioned with the dialysis patient lacking access to transportation and you fixing that doesn't sound like doctoring, right? I mean, it had a profound impact in his life and incredible. He probably went from needing to go every week to zero. The insurance plan probably called you saying, hey, what happened the last 6 months? The patient hasn't come to the went from costing $20,000 a week to zero, which is amazing. But for the students especially, or the younger doctors in training, what would be the advice that you give them about the importance of understanding and even just living in and practicing in value-based care?
I think I would say a couple of things. One is seek it out. That's one. Two, demand that your system has these resources, and I say that very intentionally. Meaning, I think that our learners have a lot of power in sometimes being our conscience. For those of us that have been doing this for a long time. And at least in our institution, we listen to our students and our residents, and we know that they're often young and a bit naive, and that naivete can be really good because it brings a perspective that perhaps some of us older folks may have lost. So there's energy in that. So I encouraged you to speak up and get engaged. That's one thing. Another thing I would say is, value-based care in general, it can seem like this really big thing that is financially driven. And I always really try and bring it back to, yes, it is about redesigning the economics of healthcare in the US. Yes, that is actually what it's about. But it comes down to what you do every single day. And I try and bring that back really routinely. And there's a lot of really good data about this, about high value care and low value care, really highly complex patients versus patients that we see every single day. And what I can tell you is the data supports that redesigning how you deliver care every day for even the small things, like not ordering that TSH when on a yearly visit, for example, or not getting a daily CBC in the hospital on the inpatient service if it's not needed, or fill in the blank. Those things really matter. In aggregate, reducing that low value care is actually what's going to turn this ship more, because it's about how we deliver care on a routine basis, not just really managing that super highly complex person that needs individual care. Those are two different things. That's really important. We need to focus on highly complex patients, but every day, all of our primary care docs and our specialists. We don't need to refer benign hematuria all the time.
You're creating your legacy. That's what it sounds like. What is that? So in the future, what's the legacy that you hope to leave behind in our healthcare world here, especially with the shift? CMS wants everyone to be in a relationship-based model by 2030, just right around the corner. What's the legacy you hope to leave behind, especially with the transition from this fee-for-service model towards value-based care?
What a terrific question. I have to give you credit. I've never been asked that question.
Listen, here's what I need you to do. I need you to take down my wife's email address.
That's terrific. That is terrific. I have literally never thought about that question before. That's wonderful. So let me give you my visceral answer. I care deeply about North Carolina. I care deeply about the citizens of North Carolina. I know that sounds like a politician's answer, but I actually really do. My career started in taking care of teachers and police officers and farmers in this rural community. I felt really deeply connected to that community. I feel now equally connected to our state. If we can improve equitable access to care across all populations across North Carolina, if I can leave my career saying I've done that, equitable access to high quality care, let me reframe that, then I think I've done my job.
Dr. Gwynne, thank you so much for this wonderful conversation. I'm sorry you couldn't see my fancy haircut on video this time, but this was a great conversation. Thank you so much.
Oh, it's been a real pleasure. Thank you so much.
What are your thoughts on pursuing equitable access to high quality care? You've heard ours. Now we want to hear yours.
Email us at faiselandfriends@gmail.com, and your question could be featured on the podcast.
If you like this episode, leave us a review and tell us how we're doing. And don't forget to subscribe wherever you listen to podcasts so you never miss an episode.
Connect with us on social media by following Faisel and Friends.
And follow Primary Care for America on LinkedIn and Twitter.
I'm Dr. Faisel.
And I'm Dr. Dan.
And thanks for listening. This podcast is brought to you by Primary Care for America Collaborative and produced by Split Prism Productions.